we really need to take a hard look at where the money is going, because doctors are not the ones who are making billions of dollars off of all of these healthcare costs. And if premiums are so high that patients can't afford it, I mean, I am a physician and I can't even understand my own healthcare plan. Like which is embarrassing to say, but I will get on the phone and I will say, why am I getting charged so much money for my son's albuterol inhaler? And it doesn't make sense. The way that our insurance companies are set up, it's really profit over patients. And we need to get back to what I said at the beginning, which was we need to put patients first.
Welcome to How I Doctor, where we're bringing joy back to medicine. Today, I'm joined by Dr. Shikha Jain, a board-certified hematologist-oncologist, professor at the University of Illinois Cancer Center, and founder of Women in Medicine, one of the most influential organizations pushing medicine toward real gender equity. She spends her days treating patients with oncology's toughest diagnoses: pancreatic cancer, colorectal cancer, neuroendocrine tumors, and simultaneously running a national nonprofit, hosting the Oncology Overdrive podcast, and raising 3 kids. If you've seen conversations about the gender pay gap, about physician harassment, or why women make up 55% of med students but only 14% of department chairs, there's a good chance Shikha's research or advocacy was probably behind it. Her signature philosophy, fix the system, not the women, reframes gender inequity as not just a pipeline issue requiring resilience, but as a structural failure requiring institutional accountability. I could not agree more. I'm particularly excited for this conversation because she doesn't just study these problems from the outside, she lives them from the inside. Dr. Shikha Jain, welcome to How I Doctor. Before we jump into the episode, I want to thank our newest How I Doctor sponsor, Savaro. Savaro is a top telestroke and neurology company that was built to fix one of the most predictable failures in modern medicine, getting timely, consistent access to a neurologist when you actually need one. Their team of board-certified neurologists deliver rapid video response, clear decision-making support, and continuity from the first exam all the way through treatment planning and management. Hospitals working with Savaro see faster door-to-needle times, fewer transfers, and measurable improvements in patient outcomes. And because Savaro was built by physicians, the workflows actually match real-world medicine. If you need stronger, faster, and more predictable neurology coverage, visit savaro.com to learn more. And now, let's get into today's episode.
Thank you so much for having me and for that lovely introduction. I'm so excited to be chatting with you today.
Shikha, was there a moment when you decided to kind of take on activism and talk about these things more openly? Has that always just been your personality since you were a kid? Or did something actually frame this and say, yeah, I'm actually going to stand up and do something about it?
I'm the kind of person who, if I see something that's wrong or not just, I would always speak up. It's a part of who I am. I mean, I have a younger brother and my parents joke all the time. Like if somebody was breaking a rule or someone was doing something not right, I would get something in the pit of my stomach and I was like, I have to say something. So it's kind of intrinsic in my personality. I used to think of advocacy work as, oh, you go to the Hill, you lobby, writing bills. Like that's where I thought advocacy lived. And over the last decade or so, I've really realized that there is so much more to advocacy, whether it's patient advocacy or whether it's, clinical advocacy or changing systems. There's so many ways to do that, that I very proudly wear it as a badge of honor now. But I really didn't realize that's where I was heading when I started doing some of this work about a decade ago.
What was your vision in your head of what you wanted to do and then what you were doing?
So my dad's a physician. He had a private practice. He actually was the president of a multi-specialty group for years, and he became a national leader in vascular surgery as a private practice clinician in Kalamazoo, Michigan. So I always thought I was going to go to med school, do residency. I was going to become a private practice doc. I was going to see patients, have kids, have a family, and that was my dream, to be a doctor, take care of people, and have my own practice. When I went through residency, fellowship, as everybody does, I initially thought I was going to be a pediatrician, then I thought I was going to be a surgeon, and eventually I am so grateful that I found this amazing field and I became an oncologist. And when I was in my fellowship, actually, the way I ended up in academics to start was I was looking for jobs, and I was actually looking for private practice jobs because that was in my head what I thought I was going to do. And then this amazing opportunity presented itself to me at Northwestern, and that's where I had my first faculty position. And I said yes. And so that's how I ended up in academics. And then the nonprofit came a few years later with all the work I continued to do.
Oncologists and nephrologists, you guys know your patients so well. I can just tell you the name of the person, and often my oncology colleagues can just start rattling off like, "Oh yeah, their CT 6 months ago showed disease progression, but then we repeated a thing and put them on this new cocktail, and now they seem like they're back in remission again." Like, I think you guys are really strong advocates for your patients with a very, very serious diagnosis, and you often almost become their like PCPs while they're sick with their cancer as well.
Yeah, it's so funny you mentioned that because so when I was a resident, actually, my first really big advocacy win was I had a patient who I will never forget him. He ended up coming into the hospital, cord compression. He was really, really sick. They ended up fixing that, but he ended up paralyzed from the waist down. And he couldn't get into this skilled nursing facility because of some insurance loophole. And I was a senior resident at the time, and I called and I called and I called, and I ended up finally somehow getting the head of the company on the phone. And I was furious. I was like, this is this guy's only hope. He has survived cancer. We have fixed everything. He is now paralyzed. And you're going to tell me that you won't take him because of an insurance issue? I was furious.
Yeah.
He ended up getting accepted to this facility. And it was the first time where I, even as a resident, felt, wow, I can really make a difference in people's lives. And so I think to be an oncologist, you have to have some core like desire to advocate for your patients, especially in the current healthcare system. I feel like we're doing it even more than we normally do.
I think for many physicians, especially on prior auth and approvals and step therapy and all this, is just there is one physician and there are hundreds, thousands of blockades trying to make that advocacy work more challenging or more time consuming. There's like one of you, and there's probably hundreds of patients that need advocacy as well.
The sad thing is sometimes you have to figure out, okay, let's say I'm seeing 30 patients today. I'm going to have to do peer-to-peers and prior authorizations on X. Which ones do I need to prioritize? Because there's only so many hours in a day. They only give you a certain window. You're seeing patients. How do you, I just literally 5 minutes before I got on this call, I got a message that I have to do a peer-to-peer on somebody who needs a CAT scan to rule out a pulmonary embolism. And I responded, I said, this is absurd. And
Yeah.
they said, we agree, Dr. Jain, but this is the number to call to speak to somebody. And so I mean, it is unfortunately become a part of a very broken healthcare system that is now integrated into us balancing that along with everything else we do for our patients.
Shikha, is there a moment where your frustration really made you decide, okay, I'm going to create women in medicine? I'm going to take this from me individually trying to help one patient or individually try to access this and say, okay, I'm going to step back and I was a social policy major at Northwestern, so you've already sold me on this, but what's the moment that you decided, okay, I'm going to actually turn this into an organization, into a nonprofit?
There's two key moments when all of this kind of started. So first, I had just given birth to my twin boys, and I was doing a little bit more work online, advocacy work. I was doing a little bit more just on social media. And I started noticing women posting things that seemed very similar to my experience going through my, my training and my career, where I thought I was the problem. I thought that I didn't get an opportunity because of me, or I thought I was talked to a certain way or bullied or harassed because I was the problem and that's just the system and I just have to deal with it. But these women were posting stories and I said, holy cow, I grew up in a physician household and I did not realize what a systemic problem this was. If I am an informed individual who came into medicine knowing what medicine is, and I did not realize that I was not the problem, I was at home crying, saying, oh my gosh, this person did this to me, but it's really my fault because I didn't do well enough, then obviously there's something wrong with the system. And so I decided to create a conference. And I was at Northwestern at the time, so I created the first ever Women in Medicine Symposium at Northwestern while I was there. And it was a huge success. I ended up leaving Northwestern for another job at another hospital a couple months later, and I realized there was such a need for this. And so I launched the Women in Medicine Summit. This was September 2019, and March 2020, pandemic happened.
Yeah.
And all of these people started reaching out to me. They said, "Oh my God, you created this amazing thing. What are you going to do?"
What's going to happen? Yeah,
Right.
yeah.
And I said, "I don't know. I'm trying to survive a pandemic with 3 children in a condo with a 2-position household." But I realized, I said, "So first we made the conference virtual." I said that we're going to be virtual. And the second thing is I started launching a speakers bureau. We launched a research lab. We launched leadership programming. We launched allyship programming. So we launched all of these things because I realized it wasn't just the summit that was so powerful. I mean, it's great to educate, but we also need to provide opportunities so that we can change the system itself. And so that's why we launched all of these initiatives. And my dad actually one day said to me, "Honey, I love everything you've done. This is way beyond just a conference. You need this to be under an umbrella of some type of
Mm,
organization." And so that's how I joke my autobiography will be called How I Accidentally Started a Nonprofit, because that's what happened. So
yeah.
2021, we became an official 501(c)(3). And since then, we are heading into our 8th summit this fall. And we've now launched an ambassador program where we're kind of activating women around the country to give them ownership of their own careers and also to give them skills and tools and networks to help them change systems within which they are. But we need to be doing this work year round. And we don't just need to be educating the women, we need to be empowering them. We need to be empowering men to stand with women to drive this change. And then we need to look very deep and do a deep dive into our healthcare system and figure out how do we actually make the changes that will not only allow for a sustainable workforce, but we also need to realize that by focusing on the workforce and focusing on the healthcare systems themselves, we actually can positively impact the health of our communities. Data keeps consistently showing when there's women physicians taking care of patients, they're less likely to be readmitted to the hospital.
Yeah.
Women surgeons have a lower mortality and morbidity, meaning their outcomes are better. And I want to emphasize this is not us versus them. This is not women are better, men are better. This is really about how do we support and elevate the people who are doing this incredible work. We're not, a factory where we're making widgets, right? We are
Yeah.
doctors and nurses. We are people who people's lives literally rest in the hands of the decisions we make. And unfortunately, many of those decisions are being taken out of our hands. My biggest pet peeve is calling patients customers. This is not like a plumbing issue. We need to get away from this, business model of medicine where private equity is taking over everything and we're not focusing on helping our healthcare workers do their job to the best of their ability.
I want to take a moment to thank our sponsor, Savaro. If you've ever waited and waited for a neurologist to call you back, you know the problem that Savaro was built to fix. Savaro is a physician-led telestroke and neurology company that delivers rapid virtual neurology coverage that's reliable. Their board-certified neurologists connect by video in under 45 seconds, and they stay with you through the entire decision-making journey. Hospitals working with Savaro report faster door-to-needle times, fewer unnecessary transfers, and measurable improvements in patient outcomes. If your hospital needs stronger, faster, more consistent neurology coverage, visit Savaro.com to learn more. I mean, that's part of the reason I started this podcast and the company Off Call is we need good people in medicine. We need people to not quit and leave. I wanted to inspire people to hear from other physicians who are trying to make a difference in healthcare, to make them maybe feel like they have something they can do as well to contribute. Because, look, you and I are going to get old and get some disease at some point that we're going to need a good, caring fellow human that's highly trained and highly experienced to help us with our weird thing that we get, because doctors and their families always get weird shit, I mean, and I really worry that fewer and fewer people will want to do this work because they see how much harder it's gotten and how much less enjoyable it becomes when it's all filled with prior auth and bureaucracy and paperwork.
And the first op-ed I ever wrote was actually in response to a Forbes article that came out. And the Forbes article was written by a physician, and it said something to the effect of, "Mamas, don't let your kids grow up to be doctors." And I was furious. I was like, "No, this is a horrible message." And I wrote an op-ed about why I wanted my daughter to become a physician. This is before I had, 3 kids. I was just a mom of one at that time.
Yeah.
And now 10 years or 11 years later, I am seeing more and more physicians who are saying that. I mean, we've
Yeah.
seen
I
physicians.
agree.
It's scary, and we've seen
Yeah.
physicians under attack in the news, physicians under attack in real life. Like, I've had patients yell at me and attack me and threaten me and tell me that I'm a bad doctor because I'm telling them to get the flu vaccine or the COVID vaccine. I mean, it's exhausting. So I worry that we're going to see more and more people leaving the healthcare space, and the fact that we have doctors telling their kids not to be doctors makes me sad.
Yeah, absolutely. I don't want to actually presume that I know what you think needs to change. So maybe can you tell me, like, what do you think does need to change? I think I'll probably agree with you, but I'm actually really curious.
It's a complete remaking and a re-envisioning of our healthcare system. So first, think ideally, right? We need to have a system that focuses not on profit, which a lot of hospitals are not profit, non-for-profits, right?
Yeah,
But they're really not,
they're
right?
making lots of revenue. Yeah, yeah,
Their CEOs are not for profit. So
yeah,
I think the first thing is we need to put the patient first. So how do we do that? So first of all, obviously, hospitals are businesses. They need to make money. They need to maintain their revenue. But the first thing we need to do is every decision that we make, we need to think about how is this impacting the patient? Not just patient satisfaction, but how is it like thinking about the patient as an individual and walking through the system. I'm a patient. I was just diagnosed with X. I need to get this, this, and this done. How can we make that process seamless? Because a lot of patients, we lose them in between, and community health gets worse because they show up and they're like, you need these 6 appointments. No one calls. And then all of a sudden they're not seen for 5 years and they've got metastatic colon cancer. So I think that's big picture. Then let's talk. I mean, we talk about outcomes, right? The RVU system became a really big thing.
yeah.
And the problem with the RVU-based system is I don't think the RVU-based system actually compensates or supports physicians in the way that it should when it comes to how it's actually valuing the care you're giving. Primary care docs are reimbursed at very, very low levels compared
Yep.
to specialists, but primary care doctors often spend a lot more time with their patients. They are preventing them from getting sick, which is saving the healthcare system billions of dollars, but they're getting reimbursed at very low rates. So we're seeing less and less primary care docs. So we need to think about how can we invest money in getting good primary care docs, keeping good primary care docs, and investing in preventative care as opposed to just reactionary treating the cancer when it shows up. I also think we need to think about how we reimburse physicians and people for the work they're doing. I mean, so let's talk women for a minute. Women are more often to be voluntold, to be on a committee. They voluntold to mentor, to do all of the things that actually maintain hospitals, retain their
Accreditation. Yeah,
exactly,
yeah,
but
yeah.
none of that's compensated, and oftentimes that stuff also does not go towards your promotion. It doesn't go towards building your career. It's just work that you have to do, and so a lot of people do it in their free time. I know a lot of women who 11 p.m. to 2 in the morning is their most productive time for all of the stuff that they need to get done that's uncompensated work. So I think that we need to be thinking about how are we valuing the work that's actually being produced. And this RVU model, again, it goes back to that widget idea. Like, people are not widgets. I might have 2 patients with the exact same diagnosis. I have to spend an hour with one of them and 15 minutes with the other. But the billing is the billing doesn't make sense. And so the RVU model and just saying to see more and more and more patients is not the best way to take care of patients, and not compensating people for the time that they are responding to my chart messages
Yep.
on the, writing notes, doing all of the extra stuff, the peer-to-peers, the prior authorizations, all the things that lead to burnout, I think are definitely contributing. But I think we really need to take a hard look at where the money is going, because doctors are not the ones who are making billions of dollars off of all of these healthcare costs. And if premiums are so high that patients can't afford it, I mean, I am a physician and I can't even understand my own healthcare plan. Like, which is embarrassing to say, but I will get on the phone and I will say, why am I getting charged, so much money for my son's albuterol inhaler, and it doesn't make sense the way that our insurance companies are set up. It's really profit over patience. And we need to get back to what I said at the beginning, which was we need to put patients first. The final thing I'll say about this, I think physicians have been cut out of a lot of the decisions. And I think we really need to focus on getting physicians back into those rooms where these decisions are being made. And not just, I mean, I have a lot of physician colleagues who are executives who've stopped practicing, and I appreciate them. I think they're wonderful. But I think you need to have physicians who are on the ground taking care of patients, because it's very easy to write a policy where you say, oh, this is only going to impact, 25 patients a month. I've told an administrator before when they made a decision that I'm not going to say which hospital I worked at many at a hospital I was at, I told the administrator, I said, if you're going to make this decision, this is going to negatively impact my patients. Every single time my patient is negatively impacted by it, when I'm having that conversation with them, I am going to call your cell phone and you are going to tell this patient why this decision was made. And the person was like, "Oh, well, that's not, HIPAA." And I was like, "Oh, no, I'll get permission first, but I will make sure that you are the person telling the
Yeah.
patient why this decision is made, because you are looking at the bottom line of the hospital, which I get, but you are negatively impacting patients by making this decision, and I'm the one who's gonna get yelled at." And most physicians are tired. We don't have time to be fighting each battle. So we need to have physicians in those rooms where decisions are being made.
I think the physician is the human being face of all of the hurdles and challenges that the patient experiences. And so the patients think we're in charge, and then they're going to kind of take it out on us or yell at us or view that it's our fault, when in reality, so much of it is, yeah, I can say, I think you need a CAT scan until I'm blue in the face, but I actually it doesn't work that good. It requires me to now argue with your insurance company, and the insurance company gets to say, well, technically, we're not denying the CT scan. We're just saying we won't pay for it if it's not approved. And so it's like this little loophole that they get to use to make it seem like they're not impacting the outcomes of patients. And you and I both know that's not the case.
We have to get back to this idea of why is this system the way it is? And it's profit over people. It really is. And we didn't bring up the fact that when these things happen, who's the person who gets sued? It's the doctor, right? If the CAT scan doesn't get done within a certain amount of time and the patient comes back with a complication, I'm the one who's holding the bag. So I was actually at a conference once and somebody suggested that the insurance company should now be sued. So if something is not happening because of a peer-to-peer or a prior authorization or a delay, patient should be suing the insurance company.
Yeah, they've got that ERISA. There's that ERISA carve out thing that makes them not liable, which still doesn't make
Exactly.
any sense to me at all. But
Exactly. It
yeah,
makes no
yeah,
sense. But
yeah.
so I think it gets back to, I mean, and maybe right now with our healthcare system in such dire straits, maybe the silver lining is the healthcare system is crumbling. Now is the time for us to really innovate and rethink a new healthcare system, taking all of the good stuff that is in our healthcare system and taking good stuff from other healthcare systems in other countries and building something that is really great.
I'm really curious. To me, as an outsider to most of oncology, I feel like oncology, since I was in med school in 2003 to 2008, oncology's had some of the biggest improvements and changes in patient outcomes from new medicines. Like, how do oncologists think about this duality of like the pharmaceutical companies are delivering new treatments that are in immunotherapies and stuff that are truly transforming your field, and at the same time, like, there's a lot of money to be made, and a lot of money to be focused on getting an oncologist to maybe do a CAR T therapy instead of a chemo. I don't, I'm literally making up these terms at this point.
Well, I mean, I wanna be very clear here. I don't think that pharmaceutical companies are the enemy. I do a lot of consulting work with them. I am actually the people who I meet who work in these companies, they care about patients. They
Absolutely.
care
Yeah.
about innovation. They actually the thing that I love is in the last, several years or so, I've really seen a real dialogue with these companies about how do we get these really innovative treatments to the patients who may not have in the past had access. So it's this really strange situation where the way that oncology has been transformed in the last 20 years is phenomenal. I mean, we are curing patients of cancers that in the past they were living for less than 6 months. And they would not be possible without clinical trials that are often funded by pharmaceutical companies. I think the challenge becomes when we, again, this is a system problem, not a person problem. How do we fix this system where profits are so much more powerful than the outcomes we're seeing?
Shikha, you've written about the invisible work that female physicians in particular tend to do more of, or that disproportionately falls on female physicians, and that it doesn't count for promotion. Have you tracked your own invisible work hours? I think your husband's a physician as well. Like, I wonder if you guys have ever compared notes on what you're asked to do.
Oh, we have. We have often. And he has said to me before, "Why are you doing all of this?" He is
Mm.
literally, he still today says this to me. We had a conversation 2 days ago about why are you doing all of this? I will say I'm much better now at saying no than I was before. But part of the challenge as women is I have been told my entire career, you have to say yes to this committee because it will help advance your career. You have to say yes to mentoring because you want to bring up the next generation. You have to say yes to this because it's for the good of the institution. And then they will see you in this light and then it will give you an opportunity. Well, I am here to tell you that
Breaking news, everyone! Breaking news.
breaking news, about 75% of that work that I've done was not acknowledged, was not appreciated. And when I was bringing it up saying, hey, I did this, I got a pat on the back and good job. Thank you for helping. So, what I've started doing is I've started listing the stuff that I'm doing and I put them into categories. So, I mentor a lot of people. And that is not necessarily something that's going to help my career, but I do it because I love it and because I do have a deep commitment and passion for helping the next generation and making sure we get really good people to stay in medicine. So for me, that is something that brings me joy. The second thing I look at is this something that will help promote my career or elevate me in some way or help in my professional development? The third thing I look at is it's something that will help me just as a human being. Is this something that I want to do because I will learn something from it or I will gain something from it? And then the fourth thing I look at is this something that I am supposed to be doing for my job, so I should do it anyway. And then the other things I say no to, and I say no politely. I sometimes will, if it's an opportunity that I think might be of benefit to someone else, I will sponsor someone else and say, hey,
Sure.
I don't have the time, but this would be great for this person. I will tell you, in the past, I've been offered leadership opportunities with no pay, no protected time, no administrative support. And I've said yes because I got a title and maybe that'll help me. Now I actually I have been offered opportunities like that I have said, thank you so much for thinking of me. I would love to do this. In order to be successful in this, in order to exceed your expectations, I would need this level of monetary support, this level
Yep.
of administrative support. And if they say no, I say thank you. Please offer it to someone else. It's up to you to decide what you should say no to and what you should say yes to. And you can't say yes to everything, which is my problem because I'm a people pleaser.
Oh, I was just going to say, I think you and I are very alike in that way. Yeah.
Very
Yeah.
much a people pleaser. But
Yeah.
I also have started thinking I have 3 kids. If I say yes to this, how is this going to impact my home life? Which before, as a woman, I've always thought about it. And I know I think about it more than my husband, although he started thinking about it a lot more over the last several years. But I also think about that because if you say yes to something, you have to say no to something else. It's just the way time works. And so I've started thinking, is this something that I would be willing to say no to something else for? And that's been really helpful as well.
Do you have an example of something you said no to recently that you might have said yes to when you were right out of fellowship or something like that?
Yes, I was invited to give a talk, which I love giving talks. I love educating. It's part of my passion. But I'm already scheduled to give 2 other talks in that same month, and they both are taking me away from home. And so I politely declined, and I suggested someone else, because my kids are 11, 8, and 8. My daughter's in 6th grade. It's an important year, and my husband helps a lot with homework, but I also help, and I also wanna be there. And so I very politely declined because I was already leaving twice that month, and it was a talk I'd given before. It was a conference I'd spoken at before, and, I would love to do it again. It was great, but I just don't have the bandwidth. And so but the good thing is I'm at a point in my career now where I can say, "I can't do this, but let me introduce you to this other person who would be fantastic, who may not otherwise have gotten that opportunity."
I noticed when you ran through your list of kind of criteria, you didn't mention pay at all. It wasn't about money or buy down in hours. Would it feel different to you if it was like, hey, we're going to pay you for your time, or, oh, we're going to buy down your time? Like, would that make it feel right or whole to you?
Yes, and I probably unintentionally left it out, but it is pay is obviously a huge part of that.
Yeah.
If it's an opportunity where I'm gonna get paid and I think I'm being paid fair market value, then I will say yes. I actually have started being very clear in that as well, like whether it's a speaking engagement or whether it's a consulting opportunity or whether it's even something within my own institution. We're in a dual physician household. We have 3 children. We are very fortunate and very privileged. But I also know, as Dr. Aurora published a couple years ago, that women make on average $2 million less in their
Yep.
career than their male colleagues for doing exactly the same work. So one of the things that I absolutely advocate for is if you're being asked to do something, make sure it's worth your time for all of the things that I said, and also you're getting paid for it, whether it's financially or whether it's paying down, taking some protected time.
You mentioned that, you were kind of socialized to say yes to everything. At the risk of being canceled, cancel me in the comments below. Like, do you think, is that a female, women are nurturing, most doctors are male, and so you need to say yes to everything? Do you think that where that comes from, or is that more of a, just a way to kind of get ahead in life more?
So I don't think you should be canceled for it. I do think that there is some truth in what you say. And actually, there's a thought that women are taught. Like, what are we taught? Girls are sugar and spice and everything nice, right? And we've been told, back in the old days, girls should be seen and not heard. Don't be difficult. Don't be bossy. Don't be aggressive. All those trigger words that we're not supposed to be.
Well, and
For
I'm assertive, but you're bossy. That's
Right.
yeah, yeah.
Exactly, exactly. And so I think a big part of it is the way society still stereotypically sees women. I mean, my husband actually, I've shown him some conversations that I've had, and he goes, "I can't believe people are speaking to you like this."
Yeah.
And I said, "Well, that is my life." I said, "I
That's
walk around
normal. Yeah, yeah.
this is he really thought, and I think society still, I mean, it's the same reason there was a paper that came out showing that women physicians spend more time responding to messages on the electronic medical record. And part of the reason is patients often feel they can ask their female physicians more. They can talk more. I've actually had patients who've come to me who've said, "I want to see you instead of a man because I feel like I can be more open with you. I feel I can talk to you more. I feel like you're going to be listen, you're going to," it's so stereotypical. Women are more empathic. Women listen more. And so I think that there's a stereotype that still exists in society. And I don't think I, I don't think it's right, but it is unfortunately the society we live in. We are starting to see some of that shift. I mean, we're starting to see in heterosexual partners, male partners stepping up more at home because we also know the invisible and visible work that many spouses do at, it's often more the women. I mean, school has my phone number. I'm the person who, if there's sick, I have to deal with it. I know all the activities. Like, that's what most women say, right? They manage the carpool, they manage the schedule, they manage. So we're starting to see that shift slowly in society, but there is a huge component of societal impact on how we see women and men. Women are bossy, not the boss.
Yeah, you brought up that study of female versus male surgeons, and I think they tried to like match cases, and I think the female surgeons had slightly better outcomes. I mean, that's part of my theory a little bit about if that's true, that female physicians and surgeons have a slight edge on us males, it's because, just like you said, patients are maybe more open to sharing. Like, hey, I'm actually still having a lot of pain, and that's maybe a sign that they're about to get a wound infection or something like that, or that maybe in the way that females are socialized, like that they are taught to have a more all-encompassing view of the patient and consider the patient's life circumstances in if you should hospitalize them or not, or should you, which medicine to put them on, versus, maybe men are socialized to be a little bit more like, well, figure it out, buddy, or, pull yourself up by your bootstraps. It's the patient's responsibility to figure that out. And then add in our screwed up healthcare system that really makes patients often like fight for yourself, try to figure out this system.
Yeah, and I think, one thing that's so interesting, if you think about how healthcare and medicine was delivered like back in the 50s and 60s, right?
Yeah.
The doctor prescribes you stuff, you go home, you take it.
You take the stuff. Yeah.
Right.
Yeah.
It was a very paternalistic way
Yeah.
of medicine, right? It wasn't a team approach. It was, I'm your doctor, I tell you what to do, you do it, and you go do it. But I think that there's still that very paternalistic, hierarchical way of thinking in medicine because traditionally that's how it's been. And men are socialized to be like that when it comes to the healthcare system. I also think that there's a certain way of teaching the next generation that men have been often taught. Well, you tell the patient, they do it. And I think that's changing. But I think, there's still a lot of people who are in leadership who were practicing in, the 60s and 70s, who are still in leadership. So,
in our last few minutes, Shikha, can you tell me something that maybe somebody that believes in this idea of fairness and equality, like what's something a male ally might think is helpful, but actually isn't helpful?
well, I think there's a lot of men out there who want to help. But they don't always know what to do in the situation. So sometimes I'm going to give you a couple of tips of what you should do and what you shouldn't do. So what you should do, if you are in a situation and you see someone being harassed, bullied, it might not even be so outward that they're like making comments on their appearance or they're doing something. So it could just be that they're like talking down to them or they're, discounting their opinion or mansplaining them. As a male ally, it is amazing if you step in and you say something because it will always mean more coming from you than coming from the female who's being attacked. So in the moment, and you don't have to be mean about it. You can. What I tell people is ask a question. Say, "Hey, I don't think that is really how you want to come across. Do you think we could like reframe the conversation or if they're being a real jerk, you can tell them, "Hey, that's not nice. Like you're being kind of a jerk." But I think that asking the question in the moment and calling it out in the moment is really good. The second thing you can do if you're in a meeting, and this happens all the time, women will give an idea and somebody else steals the idea, but they're not really stealing it, they're repackaging it. So, what I tell people is that you can be proactive. And if a woman gives an idea, after she gives the idea, you can say, "Jennifer, that's an awesome idea. Let's talk more about Jennifer's idea," and keep
Mm.
as Jennifer's idea. If someone has already stolen the idea, if Jennifer gives an idea and now John is saying, "Oh, yeah, well, I had this idea to do this and change the system in this way," you can in the moment say, "John, thank you so much for summarizing Jennifer's idea so well. Jennifer, what do you think of John's ideas in relation to what you propose?" So bring it back to the original person. And that way you're not saying, "Hey, John, you're being a jerk and you just
Yeah.
stole his idea." You're actually saying, "John, nice job summarizing what Jennifer said. Now let's talk to Jennifer about where she sees this vision going." So
Yep.
there are two ways to really be great allies in the moment. What you don't want to do is don't try to tell the woman what she is doing wrong in the moment. I've seen this happen where somebody is saying something to a female colleague and another guy comes and thinks he's being helpful because he thinks he's deflecting what the first guy is saying. And he's like, "Oh, I think John is just trying to say this, Jennifer. So maybe you should do it this way." Don't do that. That's not helpful because now she's got two men telling her what she needs to be
Yeah.
doing. And then the biggest thing, men, that you need to do, don't just suggest your friends for opportunities. Don't just suggest your male friends for opportunities. It happens all the time. It's totally unintentional. You don't even realize you're doing it. Start thinking intentionally.
Yeah.
Who is a woman I can suggest? And I'm not saying just some woman off the street. Like, women are very qualified. You can think of, I can guarantee if you think hard enough, you're going to find 3 qualified women who are just as qualified, if not overqualified for the position, as compared to your friend who you just thought of who would
Yeah.
be fun to work with.
Yeah.
Like, you need to be thinking intentionally about whose voice needs to be at the table, and you need to be saying their name when they're not in the room and getting them in that room.
Dr. Jain, where can people find your work, support your organization, learn more about you?
So you can contact me on almost all social media platforms. I'm at Shikha Jain MD on almost every platform. You can also go to my website, which is shikhajainmd.com. I try to make it easy for people. If you're interested in learning more about women in medicine, our organization, our website is wimedicine.org. We also are on all social media platforms. You can find us at WI Medicine or at wimedicine.org, depending on the platform. We are always looking for women to join what we're doing we want to elevate you. So we have lots of ways we can do that. If you're looking for a safe space to be with, join an incredible network, really, please feel free to reach out. Join us at our summit in September in Chicago, September 24th to the 26th. And if you're a guy and you want to get involved, we've got a lot of men who are actually involved with the nonprofit, with the summit. We've got allies. We have men who champion our work, and we would not be where we are today without all of the incredible people who have worked on the organization. So come find us. We'd love to have you.
Amazing. Well, thank you so much for joining me today. Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.